Hello, my name is Alex Buenrostro, and this is the critical assignment for Kinesiology 332 Lifelong Motor Development. This is the gait. This is a description of the gait development stages. The, I have a picture here of the gait cycle, which demonstrates the heel strike, feet flat on the floor, mid stance, push up, acceleration, mid swing, and deceleration. This gait cycle is divided into two sections, which is the stance phase and the swing phase. A normal gait for individuals is repetitive. It involves movement in space that are repeated over and over. For a descriptive and methodical purpose, gait has been divided into two phases, which I just explained, the stand phase and the swing phase. And the phases have been divided into specific points. These phases and points are uniformly present in normal gait. Across our lifespan, we experience a variation of locomotions, which include maturing of body segments, such as variable rotations of the limb and joints in an axis of motion, and change in posture. I have attached YouTube videos of the different variations of gait development stages within early childhood, adulthood, and older adulthood. I will begin with talking about early childhood. Children exhibit pelvic rotation at an average age of 13 months, knee flexion at mid-support at 16 months, foot contact with the trunk with base of support at about 17 months, and synchronous arm swing at about 18 months. Also heel, then forefoot strike at about 18 months. In order for infants to maintain an upright posture, they must have enough muscle strength in the trunk and extensor muscles. They must also develop a balance to be able to compensate for the shift of the weight from one leg to another. In order for toddlers to begin to walk, they must be able to support themselves on their limbs and also balance on one leg while transferring weight to the other limb. The mid-stance is very quick because the toddler does not bend the knee when shifting weight to his other limb on the step. The mid-stance is simply a lifting of the limb with a quick and short step. The toddler has very little leg and hip extension because the steps are so short. He or she steps with a flat foot and toes pointing outward. The toddler spreads his feet wide apart when planted to improve its balance. Typically, the toddler holds his arms up high in an effort for balance. All of these characteristics assist the toddler with early walking. Common abnormalities in early childhood are Trendersburg gait and toe walking gait in an absent heel contact. Trendelenburg gait results from hip abduction muscle weakness or hip pain. While the weight bearing is on the ipsilateral side, the pelvis drops on the contralateral side, rather than rising as it is normal. With bilateral hip disease, this tends to be a waddling, rolling sailor gait with hip, knee, and feet externally rotated. Now, the toe walking gait with absent heel contact is a habitual toe walking which is common in children and associated with normal tone, range of movement around the feet, and normal walking on request. However, persistent toe walking is observed in spastic upper motor neurological disease. which is called cerebral palsy. Early childhood possible constraints are functional constraints such as fear of falling or loss of balance, which may discourage locomotion. Also, environmental constraints such as noise, air temperature, and climate changes such as wind, snow, and ice may also affect the gait milestones. Some physical constraints may uh, vary from various motor milestones must have an achieved such as having enough strength to support and move himself, the ability to interchangeably move his limbs and maintain his head in an upright position. During childhood, the rhythm and coordination of a child's walk improves observably until about age 5. Thereon after, improvements in accuracy and gait continue on. The base of support for a 3-year-old is proportionally similar to an adult. Differences from a mature and adult gait include greater knee flexion, weight during stance, and slightly increased pelvic rotation, hip joints rotation, and hip abduction. However, children have achieved an adult pattern of joint angles throughout the gait cycle by this stage. Some more principles regarding childhood are: the childhood has developed a heel strike stepping gait as her foot touches the ground. The loading response is performed with a short step and noticeably bent knee. The child's steps are short and quick. The child's hip joints are still externally rotated throughout the gait cycle. Also, the child has a reciprocal arm swing with arms down. The child's terminal stance lacks full range of motion because her knees are noticeably bent and steps are short, therefore causing her to step in a flat foot on the ground plantation. Gait abnormalities that can be noticeable in childhood are stepping gait and circumduction gait. First of all, stepping gait. In stepping gait, the entire leg is lifted at the hip to assist with ground clearance. It occurs with a weak ankle dorsiflexion compensated by increased knee flexion. This is observed in a lower motor neurological disease such as spina bifida and polio. The circumduction gait is characterized as excessive hip abduction as the leg swings forward. It is typically seen with a leg length discrepancy, with a stiff and restricted joint movement, or with unilateral spasticity as in hemiplegic cerebral palsy. Some possible constraints in childhood are peers and parents. In peers, children are seen in encounters with other children in playgrounds, in the school system, and in athletics. And in several countries, there has been reported that peers influence their child's sports participation. Parents, when someone participates in physical activity after early childhood, he probably reflects his parents' interest and encouragement during the early years. Parents must encourage children to engage in either physical or sedentary activities. Moving on to adulthood, The adult stride length has increased throughout mid-adolescence, partly because of the fuller range of motion at the hips, knees, and ankles, and partly because of the increase in leg length resulting from growth. The adult walks with the arms extending at the side in an oppositional arm swing. The opposite arm and leg move forward and back in unison. Adults have an improved balance compared to infants and toddlers. Therefore, their base of support must be decreased in order to be more mobile. A normal adult gait cycle involves heel strikes, stance then toe off. The stance phase is a foot in contact with the ground, and the swing phase is a foot off the ground. In opposition from the toddler and child in walking by planting the foot flat on the ground, the adult steps to a heel then forefoot pattern, which results from an increased range of motion. The adult reduces out-toed and narrows his base of support laterally to keep the forces exerted in the backward plan. Here you see an adulthood gait abnormality. Individuals may change their walking pattern over time due to weight gain, or loss of weight gain or loss, changes in strength or balance, injury, or gait training. Any of these changes will change the constraint interaction during walking. Here you see an adult swimmer with a physical abnormality. Height, limb length, strength, and motivation can all influence the way an individual moves. For example, the disability constraint for this swimmer does not prevent him from its abilities, but it simply modifies the movement performed. Fundamental constraints are related to behavioral functions. Some examples include motivation, fear, experience, and attentional focus. For instance, you might be motivated to run several miles in a cool weather, but not in hot, humid weather. This function constraint shapes your movement to running, walking, or even sitting. Moving on to the older adult stage, older adults walk slower than younger adults, possibly to maintain balance and stability. According to the book Lifespan and Motor Development, in comparison to younger adults, older men's step was approximately 3 centimeters shorter, toed out about 3 degrees more. They have reduced degree of ankle extension, and they have pelvic rotation, which was diminished in older men. Also, some of the changes in older adults, movement patterns might be related to disease and injury in various body tissues, especially those that result in loss of muscle strength. There was an interesting study comparing persons in their 70s with healthy bodies compared to adults in their 20s, and they demonstrated about 10 to 20% reduction in gait velocity and stride length in the older population. Other characteristics of gait that commonly change with aging include an increased stance width, increased time spent with both feet on the ground. They typically have a bent posture, and they have less vigorous force development at the moment of the push-off of their feet. These changes may represent adaptations to alteration in sensory or motor systems to produce a safer and more stable gait pattern, therefore preventing injuries. A very well-known gait abnormality in older adults is the gait of Parkinsonism. In this gait, you you see slowness of postural adjustments, together with a forward flex posture, which produces the Fessenden gait, typically of the Parkinson's disease. The Parkinsonian gait has several features, which include short steps, reduced arm swing, and stooped posture. Also, postural instability evidence when the patient attempts to stand up without the use of his or her arms, or when a physician pushes on the chest or back of the standing patient. One of the most easily noticed constraints are physical constraints, which come from an age-related change in the balance of older people, resulting in compensatory responses that meet routine needs but may be ineffective under demanding circumstances. As a result, the mild age-related diseases in strength and balance may contribute to the increased incidence of falls in older adults. Also, all sensory functions also diminish with age, although it is a slow process. Another constraint is psychosocial factors, which influence the adult's activity level. Some factors of this may include limited access to facility and programs, uh, the older adult's concerns over personal limitations on exercise, lack of role models, lack of knowledge about the appropriate exercise programs, and finally, belief that exercise is harmful or ineffective in preventing disease. With that said, I would like to conclude by emphasizing that it is very important for educators, parents, and therapists to understand the sequence of the changes that occur in our lifespan from prenatal to adulthood growth. By understanding this evolutionary process, we provide ourselves a better opportunity to live the healthiest possible throughout our lifespan.